Hello everybody, this is Dr. Nadeem and we are with Niemann-Pick lectures, the Pursue series. As you are aware, all our lectures are available on YouTube and you can download them freely. We also have a Telegram group for accessing all lecture related information. You can join the group. And then we have the PDF in the Google Drive where all the PDFs are available, and there is a master integration key by which you can navigate between the PDF and the YouTube. These are the disclaimers. And we are in phase 3, which is the recorded pathology lectures, which is convenient for the teachers, the students, as well as for the organizers. And today we have Pursue 23G, which is genetic disorders, and we are streaming live from AIIMS Bhubaneswar, India. And to talk on today's lecture, which is genetic disorders session 2, which is the Mendelian disorders, we have Dr. Amit Kumar Adhya. He's an MD from PGIMER-Chandigarh. Presently, he's a professor in the Department of Pathology and Lab Medicine, AIIMS Bhubaneswar. He's also been the ex-professor of Kalinga Institute of Medical Sciences, Bhubaneswar. He's got about 118 publications in international and national journals, 1 book chapter, 6 funded projects, with 21 years of teaching and research experience, and completed 5 collaborative research products funded by DBT and BRNS. He's also got the Best Paper Award in the IAPM 2005. So let me request Dr. Amit Kumar Adhya to start his lecture on genetic disorders, which is Mendelian disorder for the day. Thank you so much. Dr. Amit Kumar Adhya, all you.
Hello students, welcome back. In this video, I shall discuss about some of the common genetic disorders. The human genetic disorders can be classified into 4 types. The Mendelian disorder, which follow the classic Mendelian laws of inheritance, also known as the single gene disorders with large effects, the best example being sickle cell anemia. There are disorders known as chromosomal disorders, the best example of which is the Down syndrome. Here, one or multiple chromosomes are involved in the disorder. Then we have disorders like cancers and diabetes, which involve multiple genes. A single gene is not involved, rather multiple genes, when mutated along with certain environmental factors, they give rise to this kind of disease. So they are sometimes also known as complex multifactorial disorders or complex multigenic disorders. Apart from that, there are some rare diseases which involve single gene, but they do not follow the Mendel's laws of inheritance. Hence, they are known as single gene disorders with non-classic inheritance. For example, the triple nucleotide mutations and gonadal dysgenesis. We shall discuss about these disorders later on. Let us first focus our discussion on the more common disorders such as the Mendelian disorders. The Mendelian disorders, as I said, are single gene disorders and they follow the laws of inheritance proposed by Mendel. These diseases can be either autosomal or they can involve the sex chromosomes. Autosomal disorders can be autosomal dominant or autosomal recessive, the difference between which we have already discussed in the previous lecture. If you pay attention to these two tables, you will find that most of the metabolic disorders fall under the category of autosomal recessive disorders. Also, the disorders which involve the hemoglobin chain fall under this category. Most of the glycogen storage disease, lysosomal diseases also are included in this category. Whereas the autosomal dominant disorders mostly include those which involve mutation in the structural genes such as hereditary spherocytosis, Marfan syndrome, or include certain receptors and their pathways. Please spend some time, pause this video, spend some time on these two tables. Try to read these tables multiple times and remember it, because a lot of MCQs are frequently asked from these tables. Sex-linked disorders are mostly X-linked. Y-linked disorders are very uncommon. We'll discuss the reason later on. So most of the sex-linked disorders are X-linked and many of them are X-linked recessive. This table enlists the most common X-linked recessive disorders. The Duchenne muscular atrophy is one such example, and you know that the dystrophin gene is involved in this disease, which is the largest gene of the human body. Apart from that, hemophilia A, hemophilia B and glucose 6-phosphate dehydrogenase deficiency are common diseases including under this category. X-linked dominant disorders are very uncommon, and vitamin D resistant rickets is a common example for such type of disorder. Let us discuss a few common clinical disorders that you will encounter. One such disease is Marfan syndrome. Marfan syndrome is a disorder of the connective tissue. It is autosomal dominant inheritance. It is a defect in a gene known fibrillin 1. Fibrillin 1 is very commonly found within the skeleton, the eyes and the cardiovascular system. Hence, a defect or deficiency of this gene or the protein fibrillin causes defects in skeleton, eyes and cardiovascular system. The fibrillin 1 gene forms a framework or a scaffolding on which collagen and elastic tissue is laid down. In the absence of fibrillin 1, there is a defect in laying down of collagen, and since fibrillin 1 is maximally present within the skeleton, eyes and cardiovascular system, these are the ones which are affected most. Another related gene, fibrillin 2, is also present, and absence or defect in fibrillin 2 leads to a different kind of disorder known as contractural arachnodactyly, that is different from Marfan syndrome. Marfan syndrome is characterized by many types of skeletal deformities. The patients are usually very tall and they have exceptionally long extremities. The fingers are long and tapering, almost look like a spider, hence the name arachnodactyly, fingers like a arachnid. The ligaments of these patients are very lax because there is absence of fibrillin. The ligaments do not have enough elastic tissue, so they are very lax. Hence these patients, they can bend their fingers backwards and touch the dorsum of the arm. They can bend their thumb and touch the wrist. Please try it on yourself. If you can do it, then you might be having Marfan syndrome. Sometimes these patients are also known as double jointed because their joints are so lax they can bend it in either direction, hence the term double jointed. The facial features of these patients are also very unique. They have a very long head which is known as dolichocephalic. The frontal bone of these patients are very prominent, which is known as bossing of the frontal eminence. The supraorbital ridges of these patients are also very prominent. If you look at the palate, the arc of the palate is very high. These patients also suffer from spinal deformities, most common of which are scoliosis and kyphosis. Scoliosis refers to lateral bending of the spine, whereas kyphosis refers to forward bending. Many of these patients have deformities of the sternum. The sternum can be deformed inwards, which is known as pectus excavatum. That is, the chest looks like a cave, or the sternum sometimes is bent outwards, or there is a bulging in the sternum which looks like a pigeon breast. Cardiovascular system is also involved. The heart and aorta are mostly involved in this disorder. Typically, these patients develop a defect in the mitral valve, which is known as mitral valve prolapse. If you see the middle picture of this panel, you will see that the mitral valve is hooded, that is, it is protruding into the left atrium. During systole, when the left ventricle is trying to push blood into the aorta, the mitral valve bulges into the left atrium. This is known as mitral valve prolapse. Long standing, this condition can give rise to weakening of the mitral valve, and hence the patients develop mitral regurgitation, which is basically backflow of blood into the left atrium during the ventricular systole. The patients develop a typical necrosis of the media of the aorta. As shown in this picture, this is a microscopic picture. The media of the aorta shows loose, blue, pale areas looking like small cysts or cavities. Hence the name cystic medianecrosis. The media of the aorta undergoes necrosis and becomes cystic. This leads to weakening of the wall of the aorta, which can rupture and the endothelium side, and blood can enter into the aorta, wall of the aorta, a condition known as aortic dissection. This is a life-threatening condition. Patient can have severe hemorrhage and bleeding and can die immediately. A very characteristic change occurs in the eye of these patients, which is known as ectopia lentis. Ectopia means the lens is at a different location than normal. If you look at the left side picture, you can see that the lens is displaced from its normal location towards upwards and outwards. Normally the lens is held in position by the ligaments, the ciliary body and the ciliary muscles. Due to absence of fibrillin and absence of elastic tissue within this area, the lens is not supported, and hence it tends to displace in the upward and outward direction, which is known as ectopia lentis. So that was all about Marfan syndrome. Another common disorder known as the familial hypercholesterolemia. As the name suggests, it is familial. That means it runs in the family. It's hereditary disorder. And in this disorder, there is increase in amount of cholesterol in the blood. Hence the name hypercholesterolemia. This is autosomal dominant disorder. As I said, receptor disorders are usually autosomal dominant, and it is a defect in the LDL receptor. To understand how LDL receptor defect leads to hypercholesterolemia, we need to understand the cholesterol metabolism. You must have read this cholesterol metabolism in detail in biochemistry. Here just I will give you a small overview of the same. If you look at the left side picture, you can see that VLDL or very low density lipoprotein is synthesized within the hepatocytes and it is released into the circulation. The VLDL consists of apoprotein C and E, B100, in addition to cholesterol and triglyceride. This moves in the circulation, and in the peripheral fat it is utilized and stored. In the muscle also it is utilized, and then it is converted to intermediate density low lipoprotein and low density lipoprotein, both of which are again uptake by the liver. This uptake is mediated by the LDL receptor. both IDL and LDL are removed from the blood with the help of LDL receptor. So absence of LDL receptor can lead to increase in IDL and LDL in the blood. On the right hand panel, you can see how the LDL receptors are formed within the cell. The LDL receptors, they are proteins, so like any other protein, they are transcribed from the DNA as mRNAs. The mRNAs reach the ribosome where the LDL proteins are synthesized. After packaging and after remodification, they are transported to the surface where they reside as LDL receptors. When they encounter the LDL, they bind to the LDL and the LDL is engulfed into the cell in the form of clathrin coated pits. The LDL is then carried into the cytoplasm and it fuses with the lysosome. The lysosomes break down the LDL into proteins and cholesterol. Proteins are broken down into amino acids. The cholesterol inside the cell is either used for formation of hormones or bile acid, or in the synthesis of cell membrane, or it is stored as cholesterol esters. An increase in amount of cholesterol in the cytoplasm leads to feedback inhibition of HMG-CoA reductase and also inhibition of formation of LDL receptors. Familial hypercholesterolemia occurs when there is any problem in the formation and synthesis of the LDL receptor. In fact, this is not a single mutation, rather mutations at multiple levels can give rise to hypercholesterolemia. There are 5 types basically, depending on whether the mutation inhibits which process of the LDL synthesis. If LDL is totally not synthesized, then this is known as class 1. Class 2 hypercholesterolemia occurs when LDL is synthesized but it is not transported. Class 3 occurs where LDL is synthesized, transported, but it does not or fail to bind with the LDL. After which, if the LDL fails in forming a cluster or forming a complex with the lysosome, the disease is termed as class 4 hypercholesterolemia. A defect in the recycling will be known as class 5 hypercholesterolemia. All these classes ultimately lead to increased levels of cholesterol in the body. Increased level of cholesterol is very bad for us because it leads to atherosclerosis, and atherosclerosis is the forerunner of cardiac diseases like heart attack. These patients usually they can be either heterozygous or homozygous. This disease is quite common, occurs in a very high frequency, like 1 in 500 individuals. A heterozygous person, because this is an autosomal dominant disorder, it manifests in both heterozygous and homozygous state. The heterozygous person have a 2-fold to 3-fold elevation of cholesterol level in their plasma. Patients develop lesions known as xanthomas and develop premature atherosclerosis. Xanthomas are nothing but collections of cholesterol containing histiocytes under the skin and forming yellowish nodules. As shown in the picture, xanthelasma commonly forms in and around the eye and over tendons when it is known as tendinous xanthomas. Homozygous, on the other hand, have a very high risk of atherosclerosis and a very high elevation of plasma cholesterol level, which is around 5 to 6-fold elevation. These patients also develop xanthomas, atherosclerosis of various arteries of the body. The patients can have myocardial infarction or heart attack at a very early age of 20. The drug of choice for this condition is statin. Statin is a drug which inhibits the HMG-CoA reductase, thereby reducing the intracellular cholesterol production. Decrease in cholesterol removes the feedback inhibition of LDL receptor, and hence more and more LDL receptors are produced which help in clearing the blood of cholesterol. The autosomal recessive disorders. The best examples are the Tay-Sachs disease and Gaucher's disease. Tay-Sachs disease is a lysosomal storage disorder of the type GM2 gangliosidosis. Here the enzyme defect is hexaminidase alpha subunit. Since lysosomes are abundant in the neurons and in the macrophages and reticuloendothelial cells, so any storage within the lysosome will tend to be stored within the neurons and the monocyte macrophage system. So these are the two cells which are commonly affected in, and this is a common finding in all the lysosomal storage disorders, the neurons and the monocyte macrophage cells of the body. Typically these patients, they show a cherry red spot in the retina. When you do a ophthalmoscopic evaluation of the eye, a cherry red spot appears around the macula. This is because the neurons around the macula, a lot of gangliosides accumulate within the neuron, making the area look yellow or pale. Leaving behind the central area which is devoid of neurons, the central area appears red. This is known as the cherry red spot. This is not unique to Tay-Sachs disease. It can be seen with Niemann-Pick as well as Gaucher's disease also. As I mentioned, the gangliosides accumulate within the neurons. On the right hand side you can see a histological picture of the brain. The neuron cell is distended by lysosomes, giving rise to a foamy appearance. These are known as foamy neurons. If you see the same thing under electron microscope, then the sphingolipids and the gangliosides will appear as whorled structures within the lysosomes. These patients usually are normal at birth, but gradually they develop mental and motor deterioration due to involvement and destruction of the neurons. They develop muscular flaccidity, blindness, and increasing dementia. They attain a complete vegetative state within 1 to 2 years of the life and usually die within 2 to 3 years. Niemann-Pick disease is a similar disease. Here the accumulated substance is sphingomyelin, and the deficiency involves an enzyme called sphingomyelinase. Type A, type B and type C, 3 types are recognized. The common character of all the Niemann-Pick disease is that there is progressive accumulation within the lysozymes and the mononuclear phagocyte system of sphingomyelin. The picture on the right hand side is of liver. The hepatocytes are normal, and in between the sinusoids there is presence of foamy macrophages. The cytoplasm of the macrophages is foamy because they have a lot of lysozymes, and the lysozymes are all distended by sphingomyelin. As I said, there are 2 types. In fact, there are 3, but type A and type B are common, and they are the true Niemann-Pick disease. Type C is slightly different. Type A is also known as the severe infantile form. These patients develop extensive neurological involvement. They have marked visceral accumulation of sphingomyelin. Visceral here refers to mostly liver, spleen and lymph nodes. So these patients usually present with massive hepatosplenomegaly and generalized lymphadenopathy, along with cherry red spot in the eye and mental retardation, dementia and progressive neurological loss. These patients, like Tay-Sachs disease, die early within 3 years of life. Type B is the mild form. The patients usually live into adulthood, hence it is also known as the adult form. Patients present with organomegaly, that is mostly lymphadenopathy and hepatosplenomegaly. These patients do not have any CNS involvement though. This is a less severe form of the disease. The Niemann-Pick type C disease do not involve mutation similar to the type A or type B. Rather, it involves mutation in the NPC1 and NPC2 gene. Here, the problem is transport of cholesterol rather than sphingomyelin, and the cholesterol is deposited within the lysozymes. There is an infantile form, and which is a very severe form. It leads to a condition known as hydrops fetalis, that is, the fetus is totally swollen and there is a lot of edema within the fetus, hence the name hydrops fetalis. Patients usually present with neonatal hepatitis and hepatic failure. It has a chronic neuronopathic form also, which is a less severe form, and the patients usually survive into childhood. Then they develop neurological deficits such as ataxia, supranuclear gauge palsy, dystonia, dysarthria and psychomotor regression. Another common lysosomal storage disorder is a Gaucher's disease. It is an autosomal recessive disorder. The gene affected is the glucocerebrosidase, and the substrate which accumulate is glucocerebroside. There are 3 clinical subtypes. Type 1 is known as the chronic non-neuronopathic form. Non-neuronopathic, that means it does not involve the brain or the spinal cord. Rather, the splenic and the skeletal involvement is mostly seen. The patients present with splenomegaly and skeletal deformities. This is more common in the Jews of the European stock. These patients have some glucocerebrosidase activity, although reduced but detectable, and patients have a almost normal lifespan. Whereas type 2 is also known as acute neuronopathic Gaucher's disease. This is a very severe form, and it is also known as infantile acute cerebral pattern. Here the glucocerebrosidase enzyme activity is totally not detectable, and hence it is very severe. Patients usually present with hepatosplenomegaly, progressive central nervous system involvement and death at an early age. The type 3 is known as indeterminate or intermediate because it has clinical presentation intermediate between type 1 and type 2. They usually have progressive central nervous system disease which begins in the adolescence or the early adulthood, and they live up to 50 or 60 age. And you might have realized from this discussion that whether it's Tay-Sachs disease or Niemann-Pick disease or Gaucher's disease, the common thing between all these is that they are lysosomal storage disorders. There is a defect in some enzyme which leads to accumulation of substrate within the lysozymes. Hence, the cells which contain most amount of lysosomes, that is the neurons and the reticuloendothelial system, are affected. So patients present with enlargement of the organs which contain a lot of RE cells, that is the lymph nodes, the spleen, the liver and bone marrow. In fact, bone marrow examination in these patients is usually done to make the diagnosis because you see the typical cells or the RE cells within the bone marrow. In Gaucher's disease, if you do a bone marrow, you see the typical cell known as a histiocyte with sea blue cytoplasm and crumpled tissue paper like appearance of the cytoplasm. These are large reticuloendothelial cells or histiocytes which contain abundant lysosomes and appear blue in color. The cytoplasm appears blue in color and gives a crumpled tissue paper appearance. In Niemann-Pick disease, you see large histiocytes. I have shown a picture of that. The neurons, even the RE cells, can show you foamy cytoplasm. It is different from this crumpled tissue paper appearance of the Gaucher cells. In Niemann-Pick, you see a foamy cell rather than a crumpled tissue paper like cell. So this is all about the common Mendelian disorders. In the subsequent lectures, I will deal with other type of genetic disorders. Thank you.